important topic for both UGs and PGs, and that is acute liver failure or fulminant hepatic failure, right? So, I will be taking this lecture in the following points. I have divided into following points. So, first, I'll be telling you the definition of acute liver failure, then, I'll be telling you the etiology, followed by the little bit of pathogenesis, followed by clinical features, diagnosis, I mean the lab investigation, and the last one is your management, right? And students, if you want to get a complete access to all the pediatric lectures as per your CBME, so please do visit my website, Pediatric Classroom. The link is given in the description box. Well, so let's get started with the definition of acute liver failure. And before that, I'd just like to say what it is, students. So, as the name suggests, acute liver failure or the fulminant hepatic failure occurs due to massive necrosis of all the hepatocytes, or it results from severe functional impairment of the hepatocytes, right? So basically, you get or you always get a long question on this particular topic. Generally, very less time short notes are asked, so always you'll be getting a long question, case based question, right? Well, so what is the definition? So, as the name suggests, acute liver failure means there will be biochemical evidence of acute liver injury, right? And by acute, you mean this occurred if the duration is below 8 weeks. Clear? Along with that, biochemical evidence of acute liver injury and no evidence of chronic liver disease. Okay, and along with that, you'll be having evidence of hepatic coagulopathy, and that is defined by your PT, that is prothrombin time more than 15 seconds, or INR more than 1.5, okay, which is not corrected by vitamin K, and if there is presence of features of hepatic encephalopathy, right? There is one more definition of your hepatic coagulopathy, that is if the PT is more than 20 seconds or INR more than 2, not corrected by vitamin K, irrespective of your presence of hepatic encephalopathy, right? So I know, students, the definition is a bit lengthy, but still you need to remember this. So let's again recapitulate once. So the biochemical evidence of acute liver injury, that is suggested by the duration below 8 weeks, there shouldn't be any evidence of your chronic liver disease, and there should be evidence of your hepatic coagulopathy. And what is that? If the PT is prothrombin time is more than 15 seconds or INR more than 1.5, not corrected by your vitamin K in presence of your features of hepatic encephalopathy, or PT more than 20 seconds or INR more than 2, irrespective of presence of hepatic encephalopathy, right? So that's all about the definition of your acute liver failure or fulminant hepatic failure, right? So now, next, moving on to the etiology. So, the first, or rather the most common etiology, is secondary to infection. And which infection? Hepatitis A is the most common cause of your acute liver failure in children, asked in MCQ as well, right? And what are the other infections, infective causes? So yes, hepatitis hep B, hepatitis C, herpes simplex virus, adenovirus, enterovirus, and so on, right? So this is the infective cause. What are the other cause? It may be secondary to your autoimmune hepatitis. It may be secondary to your drugs. Okay, like the most common drug involved is your acetaminophen or paracetamol. The other drugs are isoniazid, valproate. It may be secondary to your toxins like amanita phylloids. Okay, it may be secondary to your metabolic diseases like Wilson disease, tyrosinemia, galactosemia, HF5, that is hereditary fructose intolerance. Okay, it may be secondary to your malignancy, it may be secondary to your vascular cause, and it may be idiopathic as well, accounting for 40% cases. Okay, so that's all about the etiology of your acute liver failure, right? Now, next, moving on to a little bit of pathogenesis. So, basically, students, there will be what features of hepatic encephalopathy and why this hepatic encephalopathy occurs. Means encephalopathy means what? It's involving the CNS, your central nervous system, right? And why this occurs? It occurs due to accumulation of your ammonia, very important, this all of you need to remember, and accumulation of false neurotransmitters, GABA A receptor overactivity or overexpression. Okay, so these are the reasons of your developing hepatic encephalopathy. And why does these toxins accumulate in the body? Because the liver is not being able to detoxify and excrete properly, right? Well, now moving on to the clinical features of hepatic encephalopathy. So, what are the clinical features? So, yes, they may present to you with anorexia, vomiting, fever, abdominal pain, right? And if there may be features of bleeding diathesis due to the coagulopathy, right? And well, fetor hepaticus, right? And very important is features of hepatic encephalopathy, and there are 4 stages of your hepatic encephalopathy. So if you're not remembering all the 4 stages features separately, no problem, I'll just be highlighting you the important points and the MCQ zones from the stages. So in stage 1, very very important is students reversal of day night sleep, right? So this is the first feature the child will present to you with, and you need to pick up this feature because this is a stage 1, and if you are giving treatment in stage 1, then you can save the child, right? So that's why this is very important, and definitely the child will be lethargic. What's important regarding stage 2 is the child will be drowsy, but yet more important is there will be development of asterexis, that is what we call as flapping tremor, right? So flapping tremor develops in stage 2 of acute liver injury, right? So this is very very important from your MCQ point of view as well, and also very important from clinically, right? And stage 3 is the child will become stuporous, there will be hyperreflexia. This is also an important point. And stage 4 is the child will be comatose. Okay. So that's all about the clinical features of your acute liver failure, right? Well, now moving on to the lab diagnosis. So basically, definitely, as because it's a case of acute liver failure, so you have to go for LFT, which will show the raised liver enzymes, right? There will be raised bilirubin, there will be raised liver enzymes. Okay. Next, yes, you'll see that there will be hypoglycemia. Okay, there will be hypoalbuminemia. What else? There will be electrolyte disbalance. Yes, there may be hyponatremia, hyperkalemia. Okay, and you should definitely go for your renal function tests also, because there is a term called hepatorenal syndrome. So hepatic failure may also lead to renal failure. So you have to go for urea creatinine, very important. Okay, and in electrolytes you have to go for your phosphorus level as well. And yes, definitely in radiology you have to go for your USG. Okay, and you have to do the investigation to find out the diagnosis. Okay, that what is the primary cause of this liver failure. Okay, well, now moving on to the last part of our lecture today, and that is the management. So how you are going to treat a child with acute liver failure, very important. So first we'll be going for general measures. And what in general measures? So yes, you need to put the child in bed rest, undoubtedly, and you need to nurse the child in a very peaceful environment, right? You cannot, there shouldn't be any stimulation or minimal stimulation, because that can even, lead to your raised ICD. So, and in general measures, you need to look for or prevent hypoglycemia. Okay. One more important thing is you need to treat the electrolyte imbalance. Right? So this is very important. Next thing is you have to treat your hepatic encephalopathy, or rather you have to treat the features of your raised ICP. How you may intubate the child. If the child is comatose, definitely you have to intubate the child and put on hyperventilation. This is very important. If there is seizures, then to treat seizures you have to administer phenytoin. You have to raise the head end of the bed. Okay, head and elevation. Okay, and yes, mannitol, yes. Next thing is you need to treat the coagulopathy if present. Okay. How? Yes, you may administer FFP, that is fresh frozen plasma, and if there is severe bleeding, you may give platelet. Okay. Next is very important point is you should definitely avoid hypovolemia. That's why you should give fluid to the child. Okay. If the child is being able to take diet orally, that is, if it's the child is in stage 1 encephalopathy, then what it should be the diet? Yes, it should be a protein restricted diet. You have to give PPI, that is pantoprazole or esomeprazole, something like that. Next is you have to treat the infection by antibiotics. So what type of infection? Most commonly by Staph aureus, Staph epidermidis. So yes, you need to give antibiotics. Okay. Next is You need to treat the underlying cause. This is very important because what we had been doing till now is all the supportive measures, but this is treating the underlying cause is your definitive management. And suppose if the child had this your acute liver injury due to secondary to paracetamol poisoning, then you have to administer what? An acetylcysteine. If it was secondary to your HSV, then you have to administer acyclovir. So this way you need to treat the underlying cause. And the last point is your the last resort rather, that is your liver transplantation. Okay, this is very important, and we generally go for orthotopic liver transplantation, OLT. So that's all about your acute liver failure, students. Hope this video was helpful to you, and if you are having any doubts, please let me know in the comment box. So thank you for watching the video. We'll be meeting soon again with a lot more important topics.